expands even maybe more frequently than that.
Also, we have food next one too.
Oh, is there not food this time? Yeah. Sorry, there will be food in the future. We wanted to, today we're going to go over atrial fibrillation, and specifically kind of in hospital management. I would like to point out that we are in the midst of getting sponsorship for these rounds, so we will have food and honoraries for the speakers that we're going to have in the future. This AstraZeneca so far is the first one to actually formally commit, but I do want to acknowledge that there are a few other companies who are just in the midst of determining exactly what their level of sponsorship will be, and that's why there are reps from those companies here, and we want to make sure they feel welcome to come to every round. So it's not like this month is this company and that month is that company. They're putting into a big pot, and we're just going to draw from that pot to do these. So thank you very much for the sponsors. So atrial fibrillation, just what is it? Well, obviously everybody here knows something about it. Instead of having that nice coordinated rhythm that starts with our heart's pacemaker and goes through, hangs up in the AV node for a split second to finish the atria pumping, and then goes down through into the ventricles, it's this kind of circuitous, all over the place, little wavelets of re-entry rhythm, and often they originate in the pulmonary veins that starts the whole process. And so these are just a variety of strips of AFib. I mean, most people have an idea what it looks like, but I will point out, if you focus on this one, when it's pretty rapid, it can sometimes be hard to tell because it can look regular, but if you see any difference in R-to-R intervals, like those two there, you can appreciate, then that helps tell you it's AFib. This is probably a more common appearance for a rapid AFib. This may look like flutter, but it's really just coarse AFib because there's still not really a perfect regularity beat to beat, and that's a more controlled AFib, but again, still AFib. These are just coarse fibrillatory waves. That's a very fine AFib, someone who's been in it for a long time, and obviously a little too slow, probably dish toxic. So the basic concepts, if we're going to hit the highlights, what do we care to know? The issue of rate control versus rhythm control. And anticoagulation, who requires it and which drugs are we going to use for it? But again, this is focusing more on the in-hospital management of it. So I'm going to kind of cut to the chase a little bit about anticoagulation just to kind of get it out of the way. Because obviously the biggest issue we want to prevent are strokes, and that doesn't show up perfectly there, but there's multiple infarcts in this brain in different territories, which is a classic appearance for someone with AFib because they can go in all sorts of different areas. And the reason is because the thrombus tends to form in this left atrial appendage. So that's the little ear hanging off the left atrium. We can't image it except by transesophageal echo as far as our ultrasound goes. So ordering a standard echo will not see a thrombus there. It has to be TEE if you need to confirm it. But the left atrial appendage, probably you could fit the tip of your pinky in it pretty easily. So you could have big thrombus there, and that's why these strokes tend to be pretty devastating. Just so you can see, that's what the thrombus would look like if we did it in a TEE. There's that appendage there. There's the body of the left atrium, and all this is thrombus. That's pretty nasty. So I pointed out the strokes from AFib tend to be worse. These are strokes for people who don't have AFib, and what percentage are bedridden. And then these are the strokes for people who had it from AFib. And you can see it's almost double the likelihood of being bedridden, again, because the thrombus would be so much bigger. Here for disabling and fatal strokes in AFib, you can see the first one is disabling in the majority of patients and fatal in up to 20%. So that's why we got to prevent these, because this is pretty bad. And you can notice that AFib gets more common, this is the red boxes, as you get older. So that we usually say by about age 80, 10% of the population will have AFib at some point. But you'll notice that the amount of strokes attributable to AFib climbs kind of disproportionately higher. So the older you are, the more AFib you're more likely to have, but also the more likely you're to have a stroke from that AFib. So it's pretty nasty. High blood pressure is another big risk factor for having strokes. Really, once you're past that upper normal of 140, the risk of stroke takes off. And other things too, diabetes increases your risk. I already commented on age and high blood pressure. And then you'll see here the biggest risk is if you've had a previous stroke or TIA. So anticoagulation has always been the point of it, and I can remember when these trials started to come out when I was in my training. These are a variety of different clinical trials that compared Coumadin to placebo to see if having anticoagulation reduce the risk of stroke in non-valvular AFib. They already did it for mitral stenosis, but now they were just looking at garden variety AFib. In case you're not familiar with this kind of a graph, this is the unity line, the zero line. So any dots to the left, and I mean these sorts of dots here, means that the treatment you're investigating is better. Any dots to the right means the treatment is worse, or the placebo is better, which obviously the placebo shouldn't have any medicinal quality. These lines here are the confidence intervals, so that means how robust the data were. And so you'll see that two of these studies, the confidence intervals cross the unity line, and that means it's not statistically significant. So they wouldn't really come out and say this was better. This one is the Canadian trial, by the way, and one of the reasons our confidence intervals are the worst is because by the time all these trials came out showing really anticoagulation made a difference, the Canadian trial shut down. They said we shouldn't continue on anymore. That would sort of be unethical. So it's not like we didn't know how to do a trial. We were just a little later in the game. So I always like to point out to patients, going on anticoagulation pretty much puts your risk of stroke kind of back to baseline risk for your age. It's not that cut and dried, and certainly in hospital their risk is higher because they've got other issues bringing them to the hospital usually. But by and large, it's a nice low risk of stroke. Whereas you can see if you're not on anything, your risk is substantial. Aspirin's kind of intermediate, and people should have the attitude it's never as good as being on anticoagulation. It always has a greater risk of allowing strokes through. And here you can see it's fairly comparable to being on Coumadin but being subtherapeutic with your INR below 2. So we really want anticoagulation, but as a lot of people know, it's very underutilized. You'll notice here just slightly more than half of patients in community hospitals were on Coumadin therapy. And in fact, the academic centers, which you might think would do better than community center hospitals, didn't do any better. They had exactly the same percentage of patients. So it's underutilized, and with good reason. You know, it's one of these drugs we use, like digoxin, like what's the seizure? Dilantin, where it has a very narrow therapeutic range where you can very easily be toxic past it. And of course, the problem is when you're supratherapeutic, your risk of intracranial hemorrhage raises. So you're still at a risk of stroke, just at a different mechanism. And then when you're subtherapeutic, of course, your risk of ischemic stroke increases. So you got to be kind of ideally in this little 2 to 3 for INRs. If we look here, this is 10-year-old data, actually a little more than 10 years old in primary care practice. You'll see that 2/3 of patients weren't even being put on Coumadin back then. And that's already long after those trials I showed you were out. And of those who were, you can see a good percentage were in that therapeutic range like they should, but some were over and some were under. In fact, about double were under. I think the issue there is physicians would rather do an error of omission than an error of commission. In other words, I'd rather you were under and you had a stroke that got through than over and I caused you to bleed. I don't think that's the right philosophy to have, but that's really what ends up happening. So it gets underutilized. Now, in the real world, which is these blue bars, you'll see that less than half the time patients tend to be right in that therapeutic range. And again, a little more over, but still some, or a little under, but still some over. Here, though, in clinical trials, they do better than the real world, but that's because they're being followed very closely in a very regimented fashion. So they get, in the very best ideal situation, about 2/3 of the time the INR is therapeutic, which is still pretty poor. And then, of course, this is what patients often think when you mention warfarin. They know that up at the cottage they kill rodents with the stuff. So just to make sure you're familiar with the new drugs that are out there that can be used in place of Coumadin that do not require monitoring, and therefore they're very nice and straightforward options for these patients. The first one that came on the market was Dabigatran, known then as Pradax, and soon to be Pradaxa, if not already. We're going to match the American name. I think that's because Pradax and Plavix sound very similar over the phone, so just to avoid confusion. And you'll notice that, so there's the event rate on Coumadin of having either a stroke or systemic embolus. And if we talk about the standard dose of 150 BID, there's the event rate with Dabigatran. Much less, so it was actually better than Coumadin. There was a lower dose, 110 BID, that was quite comparable to Coumadin. So the way we kind of think about it in our minds is, if you want to reduce stroke, and that's really what we should want to do, you'd go with the full dose. If you're concerned about bleeding issues, then you could use the lower dose and at least feel confident you're doing as good as Coumadin did, plus a lower risk of bleeding complications. Second one on the market was Xarelto, which is rivaroxaban, slightly different mechanism of action than Dabigatran. And it showed, you can see there's a healthy trend to less events than Coumadin. It didn't actually achieve statistical significance to show that it was better than Coumadin. This p-value of less than 0.001 was for non-inferiority, which is kind of a fancy statistical way of saying it's equivalent, but equivalence is hard to prove, so it's kind of statistical mumbo-jumbo. Just so you know, p-values have to be less than 0.05 to be considered significant. So less than 0.001 meant it was definitely significant for that non-inferiority. But rivaroxaban didn't actually prove it was better than Coumadin, although usually when a trend looks like this, all that means is if you had a few more thousand patients and followed them for longer, you would ultimately get there. And then the third one on the market is from the Aristotle trial, Apixaban, Eliquis, the brand name, and that's really fresh on the market to the point where a lot of family docs are just starting to hear about it, but it also showed superiority over Coumadin. It did achieve a statistical value of being better. You can see that less than 0.05 was 0.011. So there's little subtle differences between the drugs. Two of them are twice a day, one of them is once a day. And this one, Apixaban and rivaroxaban, so the second and third, they're kind of in the same family, the same mechanism of action, a little different than the beta trend. So here's our current guidelines that were updated last year in Canada. Don't read the whole thing. Stop at this part, because we're going to keep coming back to this. So these are our Canadian experts who have come up with recommendations about anticoagulation. We recommend all patients with AFib or flutter, whether it be paroxysmal or persistent or permanent, we'll go over those in a moment, should be stratified using some kind of risk scoring system such as CHADS-2. So let's break away to that, and we'll just talk about CHADS-2. Physicians are getting more and more familiar with this. It's a great way to get an idea what their risk of a stroke is with their AFib. So you get 1 point if you've had congestive heart failure, hypertension, treated for hypertension. So you can be normal tensive here, but if you're on meds for hypertension, you still get the point. Age over 75 or diabetes, all those are 1 point each. You get 2 points if you've had a prior thromboembolic event. And you can see what your risk of stroke is based on your score system. Even a score of 0, even if you have none of these, your stroke rate, 1.9, is still higher than baseline, which would be 1. So, and then it increases with time. So you're talking about 18% in a year if you've got a score of 6. So, in addition to calculating the risk for stroke, back to that slide, they also recommend considering an assessment of the risk of bleeding, such as the has bled score. How convenient that has bled spells has bled. Isn't that funny? So this is a slightly different scoring system, but you'll notice some of the points are comparable for both. In other words, your increased risk of bleeding also means that you're at increased risk of stroke. For example, if you had a prior stroke, you get 1 point for this. If you are elderly, you get 1 point for this. Hypertension. Now this one's subtly different than the first one. This one you have to be hypertensive, not treated hypertensive and back in the normal tensive range. If your blood pressure is high, you get the point. If you have bad renal or liver function, you'll get 1 point, 2 if you have both. If you are actively bleeding, you get a point. If your INRs are all over the place, which obviously only applies if Coumadin is your treatment. And drugs or alcohol. And I don't like how they phrase this, because drugs or alcohol in the same 3-word combination usually makes you think of drugs of abuse. This means drugs that might make you lean, like aspirin, Pitagro, so antiplatelet stuff. But you can get up to 9 points there. And then they point out, after you've done both of these assessments, most patients should be on anticoagulation. It would be uncommon, I would say, for the has-bled score to make us say no to anticoagulation. It usually is just a reasonable way to kind of get a ballpark feeling for what the risk is. And I suppose we usually think once you're at 3 points for has-bled, that's kind of starting to be substantial. But it pretty much means, though, that your risk of stroke is also climbing. So usually it's not a reason to say no to it. It's just a reason to be maybe a bit more observant about it. For example, maybe it would make you use something like a lower dose of Fibrillation because you maybe have a lower bleeding risk. But that's the way to think about it. So our guidelines now say even if you're a CHAD score of 1, you should be on oral anticoagulation. 2 was always, it should be on anticoagulation. 1 used to be aspirin's okay, aspirin or Coumadin. But really, again, aspirin is never as good as Coumadin, so if you really want to do it properly, you should do an oral anticoagulant. Now that we have all these other drugs that are not much different than taking an aspirin a day, where you don't need to be monitored for it, that's why they say this really is the way we should go. But again, if maybe your has-bled risk score came up quite high, maybe you would go say, well, okay, I'll go with aspirin instead. They actually subcategorize a CHAD score of 0, where you are low risk, intermediate risk, or high risk, even within a score of 0. Because I've seen strokes in patients who had a score of 0. And so they say if you're a low risk, 0, nothing. If you're a high risk, 0, they recommend anticoagulation. And if you're intermediate risk, they recommend the aspirin. So how do you know if you're intermediate, high, or low? Here's how. You're high risk if you're over 65. Remember, you get a point if you're over 75. But all of a sudden, over 65 means you're automatically a high risk 0. So now we say if you're 65 and up, anticoagulation should be considered. Another high risk is if you're a female with vascular disease. Intermediate risk is female or vascular disease. And low risk means you don't have any of those. You're not over 65, you're not a woman, and you don't have vascular disease otherwise. So it's, I think the way to consider it is it's always reasonable to consider anticoagulation, especially if somebody's at a low risk for bleeding, because it's always better than aspirin. But if you're 50, you might not want to do it. But I'm not 50 yet, but I'm getting there close. I'd still think about it, frankly, because I've seen strokes in younger people. So just because it's a low risk doesn't mean it's a baseline risk like everybody else. Now here's another important point for the guidelines in Canada. They recommend if you should be on anticoagulation, any of the new agents, and I listed all 3 of them and sort of showed you their graphs, should be chosen in preference over Coumadin for all sorts of reasons. Much more consistent, better generally for the most part than Coumadin as far as reducing stroke risk, better usually for bleeding risk, consistency. There's so many reasons why it's better. In fact, the only reason probably it's not better is that it's not on ODB except for limited use. So far that's only the first 2, but the third one now will happen in time. And so cost is a greater issue. But so if you don't have a plan, you got to kind of pay for something. So that's just kind of anticoagulation a bit out of the way. Frankly, I would say if it's in hospital, unless there's a good reason not to anticoagulate, once somebody's got AFib picked up, they should be on anticoagulation because it'll open up your options as to what you can do. If somebody comes into Emerge and it's brand new, fresh AFib, even if they don't qualify according to this thing, I would put them on anticoagulation because if in a couple of days you need to cardiovert them, you don't need to worry about the TEE and all that stuff. Kind of let these guidelines apply more to what are we going to do for the long term, what are we going to do when we're discharging. But I think AFib in hospital, anticoagulate, keep your options open. So here's the terminology. I referred to this. So paroxysmal, persistent, and permanent. Ignore the top row for a moment. So paroxysmal means it comes and it goes. And it usually will stop within 7 days and truly, usually a lot less than just 7. Persistent means it doesn't stop on its own within 7 days. Usually doesn't stop on its own at all unless we do something like cardioversion. And permanent means there's no getting back. So you can appreciate that if you're not planning, this accepted, it says in brackets, there's a bit of an overlap here. If you're a persistent AFib, that means you could get them back, but you chose not to and you accepted them. That kind of puts them in a permanent category. But that's arbitrary because that's just a decision we made about their management. But so their paroxysmal comes and goes, persistent stays unless we work hard at it, and permanent means it stays for good. The initial episode, this is an interesting category. We don't really know what to do with them. Do we anticoagulate them long term? Because nobody's ever been included in those clinical trials for just having one episode ever. Do we put them on antiarrhythmic meds or rate meds? My attitude about the first event is most times they're going to flip back on their own. But I usually feel that, especially if there's a good reason as to why they had it, say they just had bypass surgery or they're in with pneumonia, things like that, I usually don't feel that we need to commit them to long-term stuff. Again, in hospital, AFib, pneumonia, I'd say, yeah, if there's no reasons not to, I would anticoagulate. They'll often flip back on their own. And so again, the decision about long-term anticoagulation can be made there. It's not wrong to do that long-term, but I'm just not sure that we really have proven what we should do for the isolated one. So just to keep in mind, there's lots of reasons why people get atrial fibrillation. Increasing age, probably just the standard remodeling that hearts go through as they get older with little bits of fibrosis contributes to that. The high blood pressure, heart failure, so anything that puts strain in the atria. If you have a higher left atrial pressure, you're going to probably be at greater risk for AFib. Diabetes, valvular heart disease, specifically mitral valve disease, mitral stenosis in the old days when they had lots of rheumatic valvular disease, saw lots and lots more AFib. Diet and lifestyle issues can play a part, especially if your diet includes a lot of alcohol, the holiday heart syndrome many of us are familiar with, where people just drink a little too much to get into AFib. Common after surgery, especially cardiothoracics, we see it a lot. Probably 40% of cardiac surgeries at South Lake will have AFib for short-term post-op. And they'll cover them with Coumadin and an antiarrhythmic for like 3 months, and then if it hasn't come back, it's just standard to stop those. But there's lots and lots of things, too, that can contribute. The list is huge, but those are some of the common ones. It's progressive, so think about it. You know, as I say, there's overlap between or among these three, but paroxysmal early on, and then it's kind of persistent before it's finally permanent. And when it's paroxysmal, it's dependent more on whatever's triggering it. So like the alcohol, like the stress of the illness. Later on, it's more dependent on the underlying substrate, how the atria has allowed this to happen in the first place. So we won't always be triggers down the way. So what we are trying to do when we got AFib, well, obviously we want to make them feel better. I always say to patients, there's two things we as doctors try to do. We try to make you feel better and we try to prevent bad things from happening. So the prevent bad things from happening with AFib, in large part, is the anticoagulation part, because we're trying to prevent strokes and other embolic events. But make you feel better, well, symptom control, and that often means either rate or rhythm control, depending. Treating any underlying cardiac condition that might be contributing to this. Determining etiology if you can. Hyperthyroidism is another one, for example. I had a hyperthyroid patient not too long ago, and she presented to me with AFib. Assessing their risk for cerebrovascular events, and as I said, anticoagulating and dealing with that if needed. So a big question for a lot of people is, well, what should I do? Should I rate control or should I rhythm control? And there's lots of little trials, but the biggie, now 10 years old, was the Affirmed Trial, where they looked at both strategies and compared them head-to-head to see how people would do. So one strategy was just rate control plus anticoagulation. One was rhythm control plus anticoagulation. And they wanted to look at big outcomes. Stroke, death, and the whole question being, does one work better than the other? And I'll tell you why this was an important question. We have lots of evidence that shows that people in AFib do worse than people who aren't in it. So you might automatically think, well, won't we do better to get them back into AFib? The thing is, yeah, but that's people who are in AFib on their own versus people who aren't in AFib on their own. When we do things to get them back, we're doing strong things to them. We're shocking them. We're putting them on potent antiarrhythmic meds, which do harm a lot of people. So this was the question. How is it going to balance out to have these two strategies? Here's some of the thoughts as to why maybe being back in science would be better. Well, people would feel better. And then because they have their atrial kick back, they'll have a better exercise capacity because they'll have a better cardiac output. If you're in sinus all the time, obviously you'd have a lower risk of stroke, so therefore you might not even need the anticoagulation long term. Better quality of life, better survival, all these things were maybe going to be seen as a result. So here's how they did it. Fairly common ways we would still treat for rate and rhythm approaches. With rate, they said DIG, beta blockers, calcium channel blockers, which would be a mixture of diltiazem and verapamil. And you can see kind of about 50% for those two, so they could have combinations. And about 40% were on calcium channel blockers. Versus the rhythm arm, and I'm happy to see that 40%, the biggest percentage, were with the best antiarrhythmic we have then and still have today, and the amiodarone. But lots were on sotalol and then various different other antiarrhythmics down the way. So you'll see that early on, people were pretty well treated with anticoagulation. The yellow bars are the people who are in the rate arm. So again, no reason to expect their risk of stroke would decline because you're just trying to treat rate and let them stay in AFib. So by the end of it, probably 85% of patients were still on anticoagulation, whereas you'll notice in the rhythm arm, that started to fall off because people thought, well, if you're maintaining sinus, then you don't need your anticoagulation. I would like to point out, though, still about 70%, even in the rhythm approach, were on anticoagulation, which is better than a lot of people out in the real world as far as being on Coumadin goes. I already showed you those slides. This was one of the studies that helped to answer the question, no, even if you're in a rhythm control strategy, you should still be on anticoagulation. Because a lot of times these people are having episodes of AFib. They don't know, they can't feel it, so their risk of stroke is just as high. So we anticoagulate regardless of whether you're in a rate control versus a rhythm control strategy. We anticoagulate based on that risk scoring system I talked about before. But back then, that wasn't necessarily the attitude. So here, all-cause mortality, which is a big, big outcome, obviously, we'd like to prevent. And you'll notice that because the p-value wasn't below 0.05, there was no statistically significant difference. So we don't say that the yellow arm had less events than the gray arm, but obviously pretty close. So the trend was certainly not in the direction of rhythm control was better. It did worse being on strong antiarrhythmics, and I think we've known that for a long time. So we can try and get you back to sinus, but we do it at the expense of causing some problems with the ways we do it. As far as some of the secondary endpoints, so not all-cause mortality, but disabling stroke and encephalopathy from anoxia, and that's bad. Major bleeding, cardiac arrest, a closer division between the curves, clearly not a statistically significant difference, but again, the rhythm approach had a higher event rate, subtly, in that direction than the rate control. So certainly no advantage there. And then you can maybe argue, well, maybe they feel better. And so functional status, 6-minute walk, their New York Heart Association heart failure classification, and their angina class, none of these were different between the two. So we didn't make them feel better, and we certainly didn't prevent bad outcomes from happening. So there was no big difference there, and it really, this study really kind of put the nail in the coffin. Rate control is perfectly acceptable as an approach. We don't have to try and get everybody back to sinus. And also, anticoagulation really doesn't matter which strategy you use, you still are going to be, you should still be on anticoagulation, regardless of that. So, then we say, okay, rate control is an acceptable approach. So how aggressive do we need to be with rate? Same kind of question. Maybe getting the rates down in the 60s or 70s is better than leaving them up at 90s or 100s. So this was the RACE 2 trial that looked at that. And they had two approaches for people who were in the rate control approach. Aim for a lenient approach to it so that your resting heart rate should be less than 110, which is actually fairly high, I would say, versus a strict approach. But strict wasn't like down to 60 or 70. It was just your resting heart rate should be under 80, and with moderate exercise it should be under 110. It's kind of what a sinus rhythm response should do. Well, turns out of all of those outcomes, there was a lot there. The lenient control had less of them, 2% absolute reduction. So you had 2% more outcomes in the more aggressive approach. Now, interestingly, they didn't feel better either with that approach. So lenient control is more acceptable too. But it is fair to point out that even though this was the target of under 110, most of the patients had heart rates under 100 in that arm. So it wasn't still as lenient as, I don't want you thinking all these patients had heart rates at 110. Most of them were under 100, but not down into 60s and 70s. So we can be a little more lenient about that. And truthfully, if I have somebody who is asymptomatic, whose heart rate is 90 to 100, and I can tell their LV function is tolerating it, they're in a normal echo, I don't try to bring them down lower than that. And usually we don't need to in hospital either. I do want to point out a little bit about atrial ablation, just so you're familiar with it, you know what it is, but that's never anything we would be doing urgently for in-hospital. The wait itself is a 1 to 2 year wait for this. They usually have had to have failed antiarrhythmic therapy. But just to kind of complete it so you know, I talked about those pulmonary veins. That's where a lot of the triggers from AFib episodes occur. Because it's not like pulmonary vein is venous tissue all the way, and then as soon as it gets to atrium, it's immediately the electrical tissue of the heart. It's kind of a bit of a blend, a bit of an overlap. So there are these little slips of electrical tissue in the pulmonary veins, and in fact, the left superior pulmonary vein is where the majority of them, well, not the majority, but greater come from there. About a third come from there compared to all the other veins. So they can consider trying to ablate or zap these veins. So that's just kind of a stylistic diagram of what the atria look like. Not anatomically, but you've got a superior vena cava and an inferior vena cava, and that's the connection between the two. Coronary sinus, which is the great vein. But there's those 4 pulmonary veins. And you can see that a lot of them had a lot of electrical tissue in that left superior. So ablation is where you take a catheter and you essentially destroy the tissue. In olden times, it was all burning, radio frequency, so high frequency, that tip would just get hot and burn and scar. And scar does not conduct electricity, so that's why all these ablations for various rhythms help break them, because if the rhythm is a short circuit, and you scar part of the short circuit, you break the circuit. They do now cryoablation a lot too, which is cold instead of hot. The advantage of cryo is it takes longer to permanently destroy the tissue. So especially if you're in sensitive areas like near an AV node, you have a better chance of ablating only what you want and not what you don't want. So that is specifically kind of doing an AV node ablation in this diagram, but the idea there is they'll make a little hole. They'll actually have a catheter with a little scalpel on it, and they'll make a hole between the left and right atria, and then they can get a catheter through that, and then they ablate down into those pulmonary veins. And so the ablation marks will look like these. Look, like, I mean, it's almost like a video game where there's the veins there, and you're just trying to pow, 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 pow all around it, so that any electrical impulses that come from the veins will just hit brick walls and won't be able to turn into the whole left, or the whole AFib episode. It's not a cure by any stretch. Other ablations are very curative. This one is better to think of as just one of the other things we use like antiarrhythmics. It's meant to make them feel better. If somebody never has AFib again, that's a bonus, but it's meant to say it'll be less often, less bothersome when you get it, shorter duration, might still need antiarrhythmics, but at least they'll do better with that combination. So probably 80 to 90% are successful when we take that approach. So here's our Canadian guidelines of what we should do with AFib in general, kind of looking at all of these different groups. And then we're going to go through some case studies that will reflect maybe how we would approach that in hospital. So newly discovered AFib, so that's that first episode. Somebody's never been known to have it before. If it's paroxysmal, you don't need to do anything with it, as I said, unless they're bothered by it, or especially if they're in trouble. And again, the anticoagulation is questionable when it's a first-time episode ever. If they have a first time and they're stuck in it, they don't flip back on their own, then one option is to accept it as permanent. Again, rate control approach, anticoagulation is a separate question, versus the rate control here and rate control or consider antiarrhythmic therapy, and that's usually driven by symptoms. If they're bothered by it, and some people feel the irregularity, they're nightmares to treat because sometimes they feel it even when they're well controlled. So then you're taking them down that path. And you might need to cardiovert them and then keep them on antiarrhythmic meds. And as I showed you, the Affirmed Trial says, if anything, the trend is in slightly greater direction. So they usually will need it long term unless there was an acute episode like cardiac surgery that triggered the whole thing. The worst nightmare of patient population is probably this one, the recurrent paroxysmal, in and out, and in and out, and in and out. And they can often be very unhappy or very angry about their condition. It's nice when it's like no symptoms. I feel it. Doesn't bug me too much. 6 hours or so, a couple times a month, I can live with it. Anticoagulate and whatever rates they're needing, or medications they're needing for rates, if they need any at all. Versus the person who's really bothered by it, it drives me nuts. And again, that's different for different people. I have people who have AFib 3 times a week. They're okay. I have people who have it every 2 years. I got to do more to make them better, because every 2 years just drives them nuts. So then you're again talking about these antiarrhythmic meds, and again, ablation is always an option down the way if the meds fail. They usually want 2 med trials before they go down that path, and again, they're going to be waiting a good 1 to 2 years to have it done. And if it's really, so again, meds won't usually get them back. If you're going to take the approach that you need to shock them, you're going to usually need the shock, the electricity gets them back to sinus, the meds keep them back to sinus. And in my experience, most times, if we're going to shock them, it's better to have the meds on board in advance, the antiarrhythmic meds. You have a better success of getting them back if there's an antiarrhythmic there. And with respect to anticoagulation, I didn't specify, if you're going to cardioavert somebody, whether that's with meds or with electricity, they should be anticoagulated for 3 weeks before doing so, because that will minimize the chance of the thrombus from the appendage breaking off. And the only way to get around that is either it's so high risk to leave an AFib, you just accept the risk, or if they're intermediate to that, you can consider a transesophageal echo looking to see if the thrombus is there.
Can I ask you a quick question, Brad?
That was your quick question. Go ahead.
So what is the comfort level? So I'm used to seeing cardioversions done with crackle INR with on Coumadin. They want to see that therapeutic INR before they're taking the cardioversion. So if you're using one of the new agents, you're not measuring.
Correct. No need. So if they were on 3 weeks of any of those new agents, and they were compliant with it, I'd be happy with that.
So do you think the vast majority of physicians would be? Is there a comfort level?
Cardiologists, I think, would be. And they're the ones generally doing the cardioversions. If they're not, I don't know why they shouldn't be, but if they're taking the meds, they should. I would feel more confident about taking one of those meds I don't monitor than taking Coumadin for 3 weeks, because, I mean, it's a nightmare. At least a third of the time they're all over the place, especially when it's new. That's the greatest time you're going to have the super and sub-therapeutic ranges. Once somebody's been on it for years, they've really regulated it well. But they're just learning what foods they shouldn't eat because it's going to throw it off, all the vitamin K and stuff. It'll just be great when you don't have to use Coumadin. But permanent AFib, again, then you're just rate control, and rates really under 100 should be acceptable. So here's some points to think about. Who isn't an ideal candidate for cardioversion if their episodes haven't been or have lasted more than 48 hours? That's kind of an arbitrary cutoff. There's not a lot of good evidence as to why 48 is considered acceptable. I've certainly seen strokes in less than 24 for people with AFib. They usually are high-risk people. But the guidelines are, and nobody would sort of fault, that if you've had your symptoms less than 48 hours, your episode of AFib, it's okay to cardiovert them without having had 3 weeks of anticoagulation. But if it's beyond that, it's too high risk really, and you shouldn't do that unless they're dire straits. We'll talk about that in the case studies. If they've been known to be a permanent AFibber, then again, you're not likely to get them back, or certainly not keep them there, because if they're a real permanent AFib, you're very likely that you're within a year they'll be back in AFib and we'll just be dealing with it again. And again, if they're asymptomatic, they're maybe not the ideal candidate, because why are we putting them through it? What do we have to gain? Because we've shown we don't have as much to gain. So the rate control strategy for people who aren't ideal, and this may be temporary, like if somebody comes in, one of our case studies will address that, if somebody comes in and we can't because they've been more than 48 hours, well, we're going to adopt a rate control strategy to begin with. Down the way we can decide, how symptomatic are you? Do we keep you there, or do we switch tactics and now go to a rhythm control? Yep.
Would you consider the area size in that?
Yeah, the left atrial size, 45 millimeters, so 4.5 centimeters, is considered a kind of a magic, again, arbitrary number, where if it's greater than that, your long-term success is lower. Usually because it just kind of tells you how much strain there's been in the left atrium, whether that be from hypertension or valvular lesions, and so therefore how much it's been remodeled. And of course, if somebody has chronic AFib, those atria get very, very big, and that sort of tells you. So yeah, sometimes we will take that into consideration. I must admit, a lot of the times I'm really trying to just stick with rate control. I think it's better for a lot of people. And as I said, even though RACE 2 aims for a less than 110, most patients were under 100 in that arm, and I would say that's most people. Most people like me would say that's our target. We like your resting rate to ideally be under 100. And I usually use a Holter to judge that, and I just look at what the mean rate was in that time frame and what it looks like. There's all sorts of meds out there for rate control, and you can find this in any kind of cardiology textbook. I won't take you through them all in detail. Diltiazem is a commonly used calcium channel blocker, more common than Brapnil, although I'd say Brapnil does a better job of getting the numbers down at lower doses. But you can run a nice continuous infusion with diltiazem, so it's got that convenience factor. Metoprolol is just kind of boluses, but it's nice, 5-5-5. Esmolol, a very short-acting beta blocker, so if you want beta blockers, but you want that infusion approach, you can do that. DIG, awful drug, really. And certainly as monotherapy, it doesn't do a very good job. Again, it's easily toxic range, and it doesn't work well if there's any increased sympathetic tone. So if people are sick, so their sympathetic drive is up, their rates will still be sky high. They usually need something else. The only people I'd say for DIG is like the little old lady who doesn't have much sympathetic tone. Tom Cruise stopped doing it 4 years ago. So, and that's the thing with DIG. It's great when they're at rest. So you'll see resting rates of 50, and then as soon as they're up and about going to the bathroom, they'll like be 150. So DIG isn't great. Who should be in hospital? Because a lot of these people could be treated in emergency and sent home, but if you have AFib with other little issues that go along with it, so if there's any suggestion of acute coronary syndrome, sometimes it's hard to tell the horse from the cart. Did the AFib trigger the acute coronary syndrome or vice versa? Because it can be a consequence of ischemia, but it's just best that those people be dealt with in the hospital. Likewise, congestive heart failure. Again, it might have been AFib that did it all. They may have healthy ventricles, but just being at 150 beats a minute contributed. But I've seen patients who are young and healthy who haven't felt well for weeks. Turns out they've been in AFib for months and didn't know, and now they've got this tachycardia-induced cardiomyopathy because it's been racing at 150 for months. So they may have weak ventricles. And obviously they've had stroke and they're kind of coming in from that aspect of things. If there's other active medical issues that have contributed to the AFib, it'd be hard to take someone with pneumonia and AFib and send them home. I think they kind of just need to be managed in the hospital. Or likewise if it's been maybe in the context of pericarditis or myocarditis or other left ventricular issues. And I think if they're going to need IV meds to control things, it's pretty hard to send them home. So just to kind of put some of these into some perspective before we get to the case studies. Again, I said we try to make people either feel better or we try and prevent bad things happening. So anticoagulation tends to help them live longer, but doesn't usually make them feel better. They feel the same, like you're preventing a stroke, so they feel better than they would if they had one. Rate control tends to be, it makes you feel better, but we've never really proven that saves lives. And ablation, again, is kind of in that strategy. And live shorter, well, this probably is in that category. We probably do more harm than good with respect to long-term events. But again, they feel better. So that's why I think it's quite reasonable to try the rate control approach unless symptoms are just not working that way. And there's a variety of things we want to make sure we think about with AFib. So obviously history, physical, investigation. So underlying heart disease, everybody should have an echo. Everybody should have a TSH to make sure we know if they're hyperthyroid. Alcohol is usually just part of the history. ECG can help tell if there's maybe underlying things that might have contributed to it. Chest X-ray for any mnemonic process. Echo, very important to rule, as I said up here, to rule out any structural things. And then usually telemetry, just to kind of get an idea of how our rate control or rhythm control approach is working. So I'm going to take some, these are all made up cases, and the first two are going to be real extremes, so we kind of deal with the obvious in this direction, the obvious in that direction, and then we'll talk about a couple in the middle. So here's a 70-year-old guy with hypertension. He's in hospital already because he just had cholecystectomy, and he develops AFib. And his rate's already okay. His rate is 75 beats a minute. In fact, he has no clue. It's just the nurse doing rounds, doing the vitals, picked up that there was an irregularity, and the surgeon ordered an ECG, and now it's AFib. But there's no acute issues with it. And he never had it before. So, either minimal symptoms or no symptoms in the context of something like a post-operative AFib, rate control is totally fine. They don't need anything different with that. I wouldn't bump up his beta blocker. I wouldn't cardiovert him. I wouldn't do anything like that. But again, the anticoagulation is indicated. Now, this guy was 70, so he already has and he's treated for hypertension. He's got a CHADS-2 score of 1 for the hypertension. Even if he was CHADS-2 score of 0, because he's over 65, he's a high-risk 0. So no matter what, we think about the anticoagulation, but then he's in this category. If it's the first time ever, it's in the context of a stressful event like recovery from surgery that was emergent. Does he really need long-term anticoagulation? Judgment call. I anticoagulate him for the rest of the time he's in hospital if there's no contraindications. I didn't think about it for 3 more months like we do with our cardiac surgery patients. If there's no hint of it again, it's a judgment call. If you got one of the new drugs out, it's a lot easier because then you don't have the nightmare of the monitor. Because you don't necessarily know if he's asymptomatic, how often it's happened before, if his rate is controlled. If he's on a beta blocker, maybe it's happened off and on. So I would never fault anyone for saying, by all means, let's anticoagulate. But it's a judgment call. Case 2, this will be a little different. This is a 75-year-old comes in to emerge, chest pain, short of breath, and he's found to have an irregular rhythm. There's his heart rate 150, his BP 80 over 50, and his ECG confirms he's in rapid AFib. So when people are unstable, you got to shock them right away. You don't really have any luxury there. These are people who could really crash quick if you didn't. So I wouldn't kind of love the idea of, yeah, let's just give them fluid and see what happens. I would shock them. Now, there could be issues of, well, he just had a Big Mac half an hour ago, and so we don't want to sedate him for that. That's a judgment call. You know, and anesthesia tells me there are ways to deal with things like that because sometimes bad things happen and people have to have surgeries and yet they haven't been 12 hours NPO. So that's a judgment call, but these are people who can really crash and go sour. So I would say you want to cardiovert that person as soon as possible and not mess with, well, let's stabilize your blood pressure first. Right? What will stabilize your blood pressure is getting back into science. Or other things too. So this guy's kind of more shocky, but if somebody was having ischemia, active ischemia, I think that's another good reason to consider it. Any questions about that? Yeah.
Would you give them an anticoagulation shot before you cardiovert or no? Just
no. I wouldn't delay it for that.
No, I mean, IV heparin and cardioversion or just cardioversion? I
would shock them first. I think the most important thing is to deal with the acute thing rather than the risk of what might happen, especially if this person has come in, you know, if something has suddenly changed. If the story is reliable for, you know, started to get sick just 30 minutes ago, I brought him in and this is the case, then there's no time for thrombus really reformed. Let's say, though, this guy was 5 days he's been putting up with crap at home. And he finally comes in because he's just almost dying on you. So he hasn't been anticoagulated. I'd still shock him. The guidelines and the recommendations of the experts are the risk of an embolic event is outweighed by the risk of leaving them in their bed. Judgment call, I mean, that was 80 over 50 at 150 beats a minute. That's pretty clear. What if it's 95 over 70 and they feel a little crappy? But, you know, like, there's gray zones, and I appreciate that. So it's always a judgment call. The sicker they are, the quicker they should get back into science. So here's one that's going to be a little more intermediate then. So here's a 50-year-old lady, comes in to emerge. She hasn't felt well for 12 hours, and she can appreciate that there's palpitations, and she's otherwise healthy. She's in AFib of 140. The emerge doc gives her a beta blocker, gets her down to 105. Pretty reasonable sort of approach. Race 2 would be happy with that. She still feels awful. So what do you do? Well, here's some options. You could cardiovert her right off the bat. You could try and cardiovert her with drugs rather than Ontario hydrotherapy. Or you could say, come back in 24 hours and we'll see, because you have a good chance it'll flip back if this is the first episode. And I would say there's no right or wrong there. It all depends on the patient. The less symptomatic they are, maybe the more reasonable that approach is. You've got an extremely high chance of flipping back into sinus. Nothing's unstable here. You can come back tomorrow morning and we can document whether you're still in it or not. And if you come back in your NPO, we can even shock it back then. So that's totally reasonable. Back in the old days, I think a lot of the patients would have just been admitted and taken that strategy. The reality now is with bed crunches and things like that, we shouldn't occupy a bed with that approach. If they need to be in hospital, that shouldn't be our approach, I don't think. Then we've got this approach. She feels terrible. We have something that we can give her very quickly that will, well, actually it should be but that will get her back to sinus, make her feel better. So I would say, even though it maybe sounds like, oh, you know, that emerge doc did that, that's a cowboy. I think they're too aggressive. Well, no, that's probably the best utilization. It gets them better quicker, and it's good utilization of beds because we won't need to occupy one of ours, and they can follow up with their family doc. And again, if it's a first time ever, then you can almost leave the issue of anticoagulation stuff to follow up later on. If it's like, oh no, this is the third time this has happened, we definitely have to address the issue of the anticoagulation, whether it applies to her or not. IV antiarrhythmics, we've already talked about how those meds kind of are high risk, although we're not talking about putting her on this and keeping her on it forever. We're talking about just trying to get her back. And that will do better than time alone. It'll get her back quicker. But some meds can, I think the next slide. Yeah, it talks about it. Usually I would use procainamide IV as my drug of choice in emerge, because then you can stop it if they start to get hypotensive, and sometimes that happens. And sometimes that strategy hasn't worked for me, and I ended up having to admit someone to CCU because they were so hypotensive. Certainly there was no getting home. Amiodarone is, again, always our best antiarrhythmic, so a bolus of that can certainly help. The reason I might think about this is that this lady said, well, I just had a Big Mac 30 minutes ago. Why are these people going McDonald's? I don't know, but I just had a big meal. So you don't want to then maybe give her the sedation. So this you could consider. If she feels too unwell that you can't send her home, but you need to do something, you can try this first. That gives maybe a few hours, and then ultimately you can shock her, because then she'll have an empty stomach if the drugs don't do the job.
So shock her and send her home?
Yeah.
Not, you don't need to admit telemetry 24 hours.
I would. If she's never had it before, again, if there's no underlying, I mean, this is where we have to make sure, are you hyperthyroid, are you pneumonia, like what did this happen for? If it didn't happen for any obvious reason, or a reason that needs to be in hospital, then I would say it's quite reasonable to just maybe watch her for a little while, especially, we usually, when we electrically cardiovert someone electively, we watch them for maybe 9 minutes, 2 hours, kind of make sure the sedation's out of their system. That gives enough time. If they feel, well enough, I would send them home. Here, to point out, as I said, amiodarone, the best drug we've got, 92% will cardiovert within 24 hours if they get amiodarone. But again, getting absolutely nothing, 2/3 of patients will easily cardiovert within that. And the younger and healthier they are, the higher the chance of that success is. So if it's been less than 48 hours, so that magic cutoff, cardiovert if you're wanting to get them back in sinus. It's quick, it's easy, it's extremely low risk. If anybody, as long as the person knows what they're doing, the greatest risk is if it's not a synchronized shock. Could put them into VF, although it can't if they're under and you've already got pads in place. It's easy to shock them back to sinus, but you look like you don't know what you're doing if that happens. But otherwise, it's a pretty low-risk procedure. You know, the biggest issues I get patients having with is, you know, the burn sensation, like sunburn, feeling from where the pads were. And of course, if they had been anticoagulated and it's been longer than 48, that's an issue. But the things you can do, you could just rate control too, if need be, depending on your symptoms. But so there's not really a right or wrong answer with that person. Let's change this one a little bit so it's a little thornier. She's the same 50-year-old lady. But her symptoms are vague. She can't say palpitation started on the dot 12 hours ago. She says, I'm not feeling this. And this has been going on for 3 days. And she's otherwise healthy, and nothing shows up except that she's in AFib at 140. So was it 3 days of AFib? Don't know. Could be 2 months of AFib, and finally her LV is starting to really suffer because it's been going so fast. She could have a grade 3, 4 LV. You don't know until you have that information. But so that's a tougher situation, and definitely not one you'd want to shock unless it's one of those really urgent situations. So again, the emerge doc gives her beta blocker and gets her rate down to 105, but she feels crappy still. So otherwise everything's the same, just that the duration's been longer. So what are our options? I already talked about how if it was important to do a cardioversion if you could ideally, but you wouldn't if there was thrombus there. In other words, it's not so high risk. Could consider getting a TEE. So what we'll do with that is we'll put them under, we'll do the TEE, and then as long as there's no thrombus in the left atrial appendage, we'll just shock them as part of the same sedation. There's a lot of hassle factors with that. The biggest one right now being I'm the only one in this hospital working here at the moment who does TEE. So it's got to be a very select situation where we're going to do that. I don't ever love the idea of TEE-guided cardioversion being a kind of, oh, this would be nice. Because again, there's nothing wrong with rate control as far as their outcomes long-term go. So that usually, I'd say in this situation, they have to be really just that close to cardioverting, regardless of whether there's a thrombus there or not, to go this approach. So the healthier they are, I'm just about to go see a patient in the CCU after I'm done here with this same scenario. Asymptomatic, aflutter, low rates, feels fine, but the numbers are low. Should we be doing a TEE-guided cardioversion? That was a question raised in Southland. I'd say he's asymptomatic. It's just anticoagulated. He's actually been in flutter for a long time, so the chance of success in long-term maintaining sinus is low. So my gut impression is probably not, but I have to go confirm. And the reason he can't get his pacemaker right away is he just had an infection, so they don't want to put that into that step. So here's another approach, and this is the one I kind of tend to opt for, I think, more realistically. But I want to see the patient before I kind of commit them to this. But take the strategy of rate control and anticoagulate for at minimum 3 weeks to allow the thrombus to be gone if there was going to be one there, or at least to be very organized so it's not going to break off before you cardiovert them. And another point about that, once the cardioversion is done, you still got to anticoagulate them for another month afterwards. That's not because they might slip in and out of AFib again or flutter. It's because even though electrically the atria are doing their job, mechanically they're not. They're stunned, so they don't move much, so thrombus can still form, and that takes weeks for them to mechanically start doing their job. So there's always anticoagulation for minimum a month afterwards, and then again, depending on Chad's 2 scoring, maybe much longer term than that. So just a few summary points here. Controlling rate is a great approach. We don't have to get back to sinus. We don't have good evidence that that's the best way to go for the vast majority of patients. But we want to cardiovert if they're unstable or they're severely symptomatic or it's a nightmare to control their rate. And we have patients like that. Again, hopefully not because they're only on digoxin, but it's 150 and it's 40. And it's like all over the place. Or sometimes it's tough. Here's another situation that I didn't bring up today so far, but in sinus, they're 48 beats a minute. And in AFib, they're 130 beats a minute. So you can't put them on more meds to slow them because they're slow in sinus. You can't put them on less meds to raise up the sinus because then the AFib will be worse. Those people, it's better when they just get stuck in AFib because then they just work on the rate control or the rhythm approach. I put this in red, decide whether not to anticoagulate. In other words, the knee-jerk should almost be, especially in the hospital with AFib and flutter, anticoagulate unless there's a good reason not to. Because you're not necessarily committing them to long-term. That's a decision made down the way. Maybe at time of discharge, maybe 3 months later and follow up with family doc or any specialists that are involved. But again, if you anticoagulate as soon as this is picked up, that gives you better options down the way. If somebody said, let's take somebody who came in to emerge and it's probably been 12 hours and then you say, well, let's just bring you in and we'll observe rather than cardiovert you now. And you're young and you don't need anticoagulation part of the Chad's 2, so we won't put you on anything. And we'll shock you tomorrow if you're still in it. But then let's say that was Friday and Saturday, things changed, or I got called away, whatever, and all of a sudden, gosh, it's Sunday, it's been 48 hours, we weren't anticoagulating her, now we've lost the approach. Do that as an option. So it's just better unless there's good reason. Just anticoagulate and you keep that option as open as possible. And also, if somebody's like 72 hours, you can guarantee it's 72 hours, more than 48, but they won't always need 3 weeks then of anticoagulation. I'd be comfortable, frankly, with another 3 days of anticoagulation. It's tougher when you don't know how long you've been in it, but and then, you know, if it's tough and you're needing antiarrhythmics and stuff, that's where usually we need kind of specialty support to sort of make the decisions as to what's best to do. But that's it. Any questions? Yes.
Right. Just wanted to speak to the reversibility of the new agents, especially starting them in hospital if they might have procedures, and also in the emerge, obviously, it's a concern. Not, because we do see the patients come in with bleeding or that question comes up a lot. Surgeons, my friend Rob Balla still digs it into me. Oh yeah, you probably put this person on. I have to go see epistaxis. You probably have one. Anyways, they aren't. Coumadin has vitamin K. We can get fresh frozen, and heparin, if it's IV heparin, we can give protamine. Of course, even without that, it just takes a few hours for it to get out of the system. The new drugs don't have awesome reversible treatments. There are some plasma concentrates and things you can give that can try to help, but they're not awesome. And my attitude about it is they have a very short effect, a short duration of it doesn't take long to kick in, and it doesn't take long to stop. So I think in product monographs, I haven't checked the one for Elquist yet, but usually they say like 72 hours before it'll be completely out of their system. So if you were going for the most aggressive vascular surgery, 72 is plenty. I've seen an anesthetist say stop 10 days before your surgery, and like 4 days before their surgery they had a stroke because they were on anticoagulated for so much time. So they work quick and they stop quick. And unless it's life-threatening bleeding, usually just stopping it is adequate. And one of the examples I suggest is low molecular weight heparin. We use that pretty willy-nilly all over the place. And it doesn't have great reversibility either. The low molecular weight chains of heparin don't respond to the protamine so well. And yet nobody sort of has the gnashing of teeth about that. And if you're giving once a day fragment, that's going to take a good 24 hours probably to get out of your system too. The studies have not shown that bleeding is a major issue. So usually I say just stop the drug, and that's good for the vast majority of patients. You can start throwing stuff at them if they're in trouble, but they would have probably had almost as much trouble for Coumadin. Like how long does it take for vitamin K to reverse things and to get the fresh frozen and infused and all that stuff? It takes hours. We would cath somebody 24 hours after their last dose of one of the new drugs. And I usually say my garden variety recommendation is just 48 for any surgeries, 72 if it's the most bloody vascular kind of surgery you might be exposed to. So the risk is a little over, I think the concern about the risk is overblown amongst a lot of people, but it is an issue. But whatever bleeding problems we might run into because of these drugs not being very reversible so quickly as compared to other things is going to be more than offset by all the bad events we're going to prevent from them, and that's why the studies have shown them to be at least as good as Coumadin, if not better. I think you're right. I mean, when we see the emerge, I see a lot more patients who come in stroke that should have been anticoagulated than people who have had bad bleeds on one of the non-reversible. Like they're also on more products.
And one of the things I'll point out to my surgical colleagues who raise this question too is I'll say you'll probably have less bleed because you won't be super therapeutic with these drugs compared to what you would have been with Coumadin, because you'll know you're at the right level of anticoagulation. So there'll probably be less of those, and it's usually not a big deal. And it's certainly not enough of a reason to say no to these drugs. Sure. And that's why our pain guidelines favor them over Coumadin.
Are all these drugs available to RVH?
The newest one, Apixaban, just at the end of 2012 kind of became available on the market, and because it was just before the holidays, they haven't even really started to start their approach to make sure everybody knows about it. But it should be, because it's just one of the many choices we have. And they all have their pluses and minuses. But the minuses are never bad enough to say Coumadin. The biggest issue with the new ones, just so you're aware, is
renal function needs to be good. Once you start getting into impaired renal function, some of the drugs have little, well, if their GFR is below 50 but above 30, you can cut down those doses and stuff. But once somebody's got impaired renal function, you're kind of stuck in the hands. Otherwise, across the board, we favor it.
Will it cause? Does it have a side effect that would cause impaired renal function?
No. It's just a matter of that's how it sort of gets metabolized. So in other words, you'll be over anticoagulated if you have impaired renal function to that extent by taking this drug. Was this useful?
It's metabolized through the kidneys, is what you're saying?
Yeah. Isn't that right?
Yeah, absolutely, really.
My dad just had hip surgery, he was on Xarelto, and he bled terribly from the wound. And finally someone said, just stop it and go on an aspirin. And it stopped within like 12 hours. It was like back to nothing. Terrible bleeding.
For the one other question I had for you, which is interesting, it's with the guidelines that it was always thought that